I would like to invite up Dr. Renata Pellegrino from the Children's Hospital of Philadelphia.
Good afternoon, everybody. Thanks, Twist, for inviting me to this talk. I will try my best to talk about a story, not actually a talk, because this is a big story for us at CHOP. I need to learn how to use this. All right, here we go. A little bit geography about Philadelphia, even though I'm not from Philly, I'm from Brazil. But I love Philly so much that I always try to invite people to come to visit us. So you have Ben Franklin, Philly Steaks, and Rocky Balboa. If you are interested, please come talk to me later. This is the location for our hospital. We are one of the top hospitals in the world for pediatrics, very proud of that. And we are located in the same campus as University of Pennsylvania. We have a lot of infrastructure always growing up, and I never know when we're gonna stop to build new buildings. So if you wanna visit me one day, maybe I'll just be in another place. This is our center. Our PI is Dr. Håkan Ersson. We started our lab 12 years ago, and in the past 10 years, we published over 600 papers. We're a quite young lab, I would say, but we are quite big as well. And the beauty of our lab and why it was going to be related to this talk is pretty much our biobank. So we're going to talk about that soon. But our center is divided in several compartments or divisions. So we do everything based on a biobank, but in the end of the day, what we want to see is a clinical trial. What we do basically is patient-driven. So we are not a sequencing factory. We are not big high-throughput lab, but we do care about our biobank. So our goal is to improve quality for our patients in the end of the day. So a little bit of disease that this is not really updated, I would say. We have approximately 500,000 samples collected for pediatrics. So we are the largest biobank in the world for pediatrics, most likely, with phenotypic data. And why I'm so making this a big deal is because not always you're going to have the most beautiful samples in these biobanks, right? So that's one of the messages here. This is a little bit of portfolio, so what we can do or what we do actually every day. So we do a core. We have a core facility as well, so we are serving the community and the campus. We also do a lot of population genetics and genomics. It used to be actually a GWAS lab, so for the first 5 years of our existence, we did hundreds of GWAS. It's we have 10,000 samples for autism, 20,000 samples for schizophrenia, and this was our main goal in the beginning when we had a massive genotyping facility, which we still have for microarrays. But then we evolved for other technologies, and now we have different things happening, including clinical trials and more specific disease-based, such as carrier screening evaluations, and more clinical settings as well. The biobank, which is my show-off time, we have about 500,000 samples collected. Majority of them are good quality blood that we can get from a physician or internally enroll with our IRB consented. And we have PBM cells, we have EBV transformed cells, everything in a beautiful scenario, right? Nothing's wrong here. But then we do have some challenging samples as well, right? Samples that are not as beautiful as a classic sample coming from a physician or a service at CHOP network. We have samples coming from dry blood spots that most are good quality, not always. And we also have saliva and paraffin and all these tissues. In my case, I have done about 9,000 blood spots in the past 9 months. And they are majority very good, no problem. But then I have always people saying to me, Renata, can you do a very different blood spot? And that's where this talk starts. So classic workflow for sequencing, things come to me, say, let's go do sequencing. And then I block sometimes things on QC level when it doesn't pass QC for some purposes. Because obviously, target panels are more sensitive for things that are not that good. Classic slide, right? As a Philly fan, this is me last year celebrating the Eagles, right? And we lost this year, unfortunately. That was a team called Patriots, is that right? So we we got the celebration of like, okay, we can go as low as $1,000 for genome. How exciting, right? And I got these amazing emails every day saying, oh, you can do a genome for $750 now. Wow, right? Amazing. No, not for clinical people. I am a hybrid lab, I'm a CLIA lab, CAP, and for clinical people, we don't see that way, that fast, that easy, right? Interpret thousands of variants, it's really challenging. So even an exome takes, for my analysts and my clinical board-certified geneticist, about 10 days, plus Sanger, plus everything else. So it's not that actually an answer yet, at least for not from my lab. So then we start to think again for target panels, right? Target panels are very powerful, it's still good. And I have my personal, like, happy time with people working with metabolic. So they always come to me and say, can we do NGS on metabolic panels? I'm like, what? And it's pretty much blood spots again. So I come again with the blood spots. And I say, why not? But then I remember, not always the quality or amount of DNA there is enough, right, for capture. So capture is kind of a little tricky. Then more and more we think about that, but we still have this kind of dual message about like how powerful like can be a panel, for example, for metabolic disorders using newborn screen paper filter and also deal with like quality and quantity of DNA. And you can answer me now saying, oh, if you go outside, you're gonna see a lot of vendors saying you can do FFPE, you can do everything with my product, you can do 1 nanogram, magic. Yes, you can. Perfect way? No, not necessarily. So we have tested, we love R&D in my lab. So I have like 2 postdocs doing R&D for me nonstop, and they love when I say, let's test this thing. A vendor comes to me and say, let's test this. I'm like, sure, I'm gonna believe when I test, and that's what happens now. Beautiful, like Emily already explained to us, this is something that all people working in sequencing want to see, right? Uniformity, distribution, not waste of space on the sequencing, not wasting of money on sequencing. But for me, it's more like really drop of exomes, right? For a clinical standpoint, how much I can drop one exome or other, or the beginning of the gene sequencing. So for me, I always want to see this, and I pretty much can see this right now happening. Another important thing, I kind of miss the humanized portion of like prime design and also probe design. So many companies now, you can just load your bed file or your list of genes, and magically in 4 hours they say, oh, we can have your results. But don't you miss like someone in a company talking to you and say, I think your design is horrible, let's revisit this? And I miss that. And then these guys actually gave me that. They helped me, and I'm not a bioinformatician, obviously, so they were like, I don't think this is a good idea, Renata. So again, thanks for humanizing the process. So let's talk about results, or the story that I want to tell about it. So I'm from this city, 22 million people, quite big. And this is my hospital, the hospital I came from. We are not only the main hospital for Brazil, but we are the main hospital for South America, so we get as a reference hospital for many other countries in there. And again, we are all in development countries, we are not rich, and we do a good job of trying to get funding to help people that have no answer at all. So I still have my friends there working in pathology, neurology, and that's where I come from psychiatry originally. And we have a lot of collaborations and efforts and grants together to trying to respond some questions that we cannot answer necessarily there because of the funding and problems. So they come to this panel for me for epilepsy, and they said, we tried this here with a vendor X, I'm not gonna mention the name, it never worked. And I'm like, okay, I don't know anything about epilepsy, so you just give me the gene list, I'll create the bed file, and I'll design this. And then I came to Mark, hi. And this is 2 years ago when ASG in Orlando, and I said, do you think we can do this? He's like, yeah, of course he does, right? And I'm like, okay, let's do it. But nobody was talking about the sample yet. We were just talking about the design, that piece of cake. And then we have the epilepsy criteria to select the patients. We have about 200 patients. So it was a big, nice, very well-characterized cohort. We are very happy with this cohort. The bioinformatics team there, the analysts, they create like a bank and like a questionnaire, and we do that, all beautiful. But then here we go. it's going to be dry blood spot. I'm saying, okay, I do 9,000, I'm fine. But that's how started butts in my life, right? Here we go. This is my blood spots. This is CAG, my center blood spot, beautiful. And this is the blood spot that I got from these people. I'm like, what are you talking about? What is this? And they said, this is like stored in a room in the back of a hospital in the middle of the mountains in Chile. I'm like, okay, all right, sounds good then to me. And that's what they want to send me. They want to send me very challenging samples. Not always you're going to have beautiful blood or beautiful saliva on an origin tube, right? We need to face this reality in clinical settings, so even in research. So I said, of course I will do this. This is going to happen. So we start to evaluate how to extract this properly. So we work with Promega and we work with AgBT technology to do the extractions and work beautifully. We were able to get DNA out of that thing. And we designed a panel with Twist, and we used that time kappa with IDT adapters, because at that time, we didn't have the core kit that Twist has now. And here we go, let's sequence this way. Bioinformatics, of course, we have the drag, and so they spent only 10 minutes doing this for me, quite fast. But then the clinical team was like hours and days doing this work. And then very pilot results, we have like beautiful on target, 80% of on target. And for me, in the clinical settings, target of 30x, beautiful. Oh, is this real? So I had 3 bioinformaticians come talk to me and say, I don't think this is really nice. I'm like, how come? Well, this is kind of weird, right? No, this is data, right? I'm not faking data. This is coming from the sequencer. You did a dragon. I don't know anything about that. GC content, very well corrected, no problem. So then we start to do digging in analysis. So we have a clinical geneticist team in Brazil doing analysis independent of us to make sure we are not creating any bias in analysis interpretation. We follow ACMG rules, looks good. We found our genes, and coverage was absolutely beautiful. No drops, nothing in the exomes that we are looking for, the main genes that we are looking in this panel. I'm just going to skip because I need to talk about part 2, which is even more exciting. So then recently, Twist released the kit for the core kit, right? They use for exomes, and their exome platform is already established in the market. And they also release, or they are releasing, I don't know yet, I'm looking for Twist people to tell me is that true. They are releasing the Neo universal adapters. I'm not going to call universal adapters. It's going to be confusing. I'm going to call super adapters, because definitely the data showed that they did something magic in that tube that changed my life. So let's talk about that. So I did 2 tests recently. So that's the beauty to have great postdocs in the lab when they are very motivated. So I said, let's do this. I got the worst FFPE samples that were there sitting for years that I tried everything in the market in the past 3 years. It never worked, never passed library prep, nothing. And I said, why not? Let's do this thing. Since Mark said you can do anything, I'm like, okay, let's do it. And we test the Twist whole exome panel with universal adapters and their core kit. And we test their enhanced hybridization too, say it that way, to see how they will perform in this FFPE, which I had no hope of, like, never gonna sequence this thing. And then we also did go back to my blood spots from epilepsy panel that was extremely horrible, the ones that I showed the picture. And I said, let's run this with their core kit and their adapters and see if that improves, right? Because I already was happy with the results based on just using other vendors' library prep and their baits, and Twist baits. So here you go. I'm very pleasant to tell that definitely a big improvement with Twist on FFPE. First of all, I have sequencing data. How come? I'm like celebrating already, right? Champagne open in a lab. So on target, this is a regular adapters. This is all Twist, the regular on the market. 67% for paraffin that was completely destroyed, and we have no idea what it was in that tube. And now 82%, 83% on target with the new universal adapters. Good job, R&D team. And then 30x, about 93 and 95. So again, for paraffin, this is amazing. And obviously, duplicate rates are almost irrelevant here. So how can you see that in a paraffin sample is very, very impressive. I'm going to move to the next. So this is the results based on the epilepsy panel. Again, same panel. I just throw the same baits from the epilepsy panel with my horrible samples and their new core kit with their new adapters. And it's side-by-side comparison. Not much change on the on-target. Again, it's probe-based efficiency, right? So the baits have always been twisted and always been good. But then I decreased my duplicate rates in half. Again, no more waste of reads and nothing on the samples. The samples are really bad. And another impacting thing for me is always the 30x. For me, I'm obsessed with that. So again, very beautiful and sophisticated results for my purpose of like testing and evaluating. And I always trying to look for like things dropping on my exons. And this is, again, the genes that we were like targeting because it's an epilepsy gene. So it's something that important for us. Nothing changed much. So this is, I have one HapMap sample and one of the patients with the mutation that we already found with the original design. And nothing really changed, but again, it's consistent, though. That's important to us, consistency, right? So my impression is high performance in challenging samples, right? I can spend a lot of time saying that it's flexible. So basically, it's flexible. You can run this with their own core kit, or you can use this with any other vendor. It's very outstanding coverage. Uniformity is there. You can see not only my data, but they have plenty of data to share, I think. The probes are agnostic, so you definitely can throw the probes anywhere you want. It's very flexible, and it's automated. So we are doing this in our Perkin-Elmer cyclones now, and we are very excited to do that. In a lab like mine, we cannot do everything manually forever. So to be able to put this in a robot is very powerful, too. And again, big assistance for design. Please don't change that. I'll be not longer a customer if you change that. And obviously, with all these like good things about the probes and everything, you have times for other things in life, right? You have more time, and this is a very demanding person in my life, so it's good to have time for her. Look at her like you better give me attention. For the epilepsy panel, my message is not always we are going to collaborate with very, I would say, rich or with resources labs like in the United States or in good countries that we have like funding or resources. Even in the United States, we are facing like a lot of problems with funding right now. So we need really to improve quality and also how much you use our resources, right? So for me, I agree with my other colleague just presented. We need also fast, efficient, and cheaper, but keep quality, right? And my lab is like patient-driven. Again, everything is based on the patient and the quality for that patient. So for me, turnaround time is really important, and all this evolution on the methods, it's extremely powerful for our deliverables, which is give a test in a fast and efficient way and save people. We don't really save much individuals, unfortunately, in an exome level, but we actually bring some peace for families that are waiting or have 3 kids with the same disease. So that's what I do every day when I go to this lab. It's just, okay, I have an ICU patient now that the parents already lost 2 individuals. So that's why we want to do this fast, right? We want a resolution for their question about what's happening to my child. A big thank for, again, this picture is also interesting. I have to explain what it is. This is CAG family. Family was not together in a Christmas party, unfortunately, because we are 85 people. It's hard to put together in a picture. But these are all the individuals involved in the epilepsy panel last year in ASG, and they are presenting posters in the same day. And I was shocked. I was like, how is this possible? We are all presenting the same day posters. So let's take a picture. And then next morning, I was presenting epilepsy. So how funny. So these are the people from my lab in Philadelphia and the people in Brazil together in the same poster section. And all of them are very outstanding people, really caring and focused in how we can really answer questions for our patients. So the big thank you is for them, obviously, and for the patients, because without them, there is no research, there is no science. And Twist for helping us to all these crazy ideas and let's do this, let's do that, let's do this. So thank you, all of you, Twist, and obviously, Richard, thank you for the new adapters. All right? All right, thank you. I'm open for questions. Thank you.